Hi, hello, I am from Mexico, from a place, Oaxaca is a place in the south part of my country. We have some beautiful ruins, and this is a special church. Well, I think everybody has talked about the position is almost the same as a classic surgery. I think very important about this is the landmarks. Actually, why I usually use this as the prior professor talked that if you have many other surgical techniques, it's easier for you to implement to this new technique. I usually mark midline and also perpendicular to it, I put another line to underline where is the disc. And between those, I put my in the blue point, the endoscope, and in the orange, the working instrument, and the middle pedicular line. Okay, this is in a patient, and in a lateral view also, it's very important. I usually mark what is my disc of interest, and between those, I put the endoscope, and in the orange, I put the working instrument. It is very important here in endoscopy that you must see where you are and where you are working, and to see your instrument. That's very important because it is it's very easy to be mismanaged. What about this is a part of the same goal in UV surgery is that as nowadays there are navigation systems sensitive, and I think the CR is still very useful for us. It's like a GPS, and when you see all the special place, there is the endoscope that where you must recognize the anatomy. As other professors told us, is very important to have the irrigation cannula in one hand, and in the other hand, the working instrument. For example, most of surgeons are right hand, so I usually put the endoscope in the left hand and the working instrument in my right hand.
Recording in progress.
What about the endoscopy system? I think everybody is very familiar with this. There are many companies. The basics is that we must have a monitor, we must have the main camera unit and a light source. And if you have a water pump also, sometimes here we use a manometer. And this is very important, the same position to have the monitor and the equipment contralateral to your view. You always have to see where you are. And as well, for your beginners, I usually use the 0-degree endoscope, and there are more angle endoscopes. I think is more they are better for stenosis, but we must be familiar with the 0-degree endoscope. And this is the cannula. And also, I think also the very important thing is that for the beginning of the surgery, we must have a muscle detacher or the dilators. This will take you time. It's very important. For example, I usually use lidocaine with the epinephrine. Okay, and this is the spinal nerve retractors. Sometimes I use it, sometimes I don't use it. And the very classic instruments, the Carrison, the Roton, okay? And there is the osteotomes. I think with this technique, everything is possible. And that's the beauty of it, because as compared to Uniportal, for example, the equipment is still very expensive. If you, sometimes also we can have the shaver system. Okay. And the radiofrequency probes. There is the special for spine surgery or an arthroscopic probe also. The radiofrequency also is very important because it is less heating than a normal bipolar. That's why I really recommend it. And for example, as I said, the orientation in this surgery for beginners is very important. With the endoscope, for example, in my left image, we can see how we can handle the endoscope. That is the right way, so we can be oriented. And in the right image, there is more comfortable, but the problem is that you will see an inverted image. This is If I try to switch to other side, for example, we will see that there is an inverted, okay? Okay, and the other very important thing is that your instruments must be harmony with it. As you see steps, we should follow the endoscope and the working instrument. And for example, what else we can use? Sometimes we use anesthesia. That's why the problem is sometimes, although we have to be very careful about taking care of the spinal nerve root. That's the spinal nerve root and the medulla must be carefully inspected. And this is, for example, an equipment for cranial nerve surgery. This is a facial stimulator. And so in the left right image, we can see there is a long probe that we can connect to the stimulator. And with a very simple, I can stimulate the spinal root. Okay? And what other things I think are very important? For example, like for transforaminal surgery, we usually do discography, and that's a very easy thing to do. Just with methylene contrast media, and also it helps us to map. For me, I have been using it for many years. And for example, this is why the methylene blue helps me, is that this is in a transforaminal surgery, and there is a bluish color that we will see, and there is a fatty tissue, and underneath we will see the spinal nerve root. Look how close we come with this approach. It is an awake patient, but what I would like to see is that it's very close to. So that's why we must be very careful about the nerve roots. Okay. And this is a video, a very basic video, just to show very basic steps. Okay. This is the middle pedicular line, as I saw you. The lateral view marking. This is with an endoscope to mark all where I am. And I think there are many options about incisions. I usually use this because if needed, I can transport to open or mini open. And then we start to dilate. Okay. We will start putting the dilators or the muscle detachment. And okay, open it carefully. And the first phase is with bleed. That's why it's very important not to, okay, put in the dilators. Okay. And this is a muscle, this is a simulator to see. Everybody, I think most surgeons put not the ugly faces of the first phase of the surgery. And that we will be very careful to control bleed. Okay, take your time with a radio frequency probe or bipolar probe. It is very important. One of the worst enemies of the endoscope is bleeding. So here is very important to control bleed. After it, in the spinolaminar junction, I use shaver usually. Okay, starting to do, and always checking where you are. That's very important. Doing the phlebectomy. Okay, control bleeding, and also this was the last part. That's why I started to use the methylene blue. This is a simulation just to see and to always see where your instrument is. Okay, be very careful, try to take care of the medulla and the spinal root and using the instruments. Okay. Okay, and finally, taking out the spinal disc. Always try to see just to use the endoscope as a shock absorber. You will have to put it down, you have to put it up, but always never miss the target. Okay. On what are my lessons, my conclusions about this? It is a versatile technique. It has an important learning curve. Okay. Simulation is necessary. It is not as expensive as uniportal endoscopy. Always control bleed. Fluoroscopy as needed. Convert to open if not possible. And simple works better. I feel also it's very important in this surgery if you are working more than 4 hours, 5 hours, 6 hours, 8 hours, and you can still do it, just do an open. It is not a mistake. First comes the patient's safety, and I think try to learn as many different techniques. I think that's important. It is not which is better. I think these techniques will be the present and the future. Thank you. And this is from Japan, where I stay as a fellow. This is a turtle. Everybody, some common surgeons compare us to turtles, but I think the basis in it is that we have to have the strength, because this it is not easy to start performing this technique. But I think that sooner or later it is better to have a hands-on. It's very important. It is not the same as a virtual, because everybody can see that, and sometimes we can see a very easy or difficult techniques, but we will have to have a hands-on in any country. Thank you very much.
Thank the Dr. Sanchez for the presentation. If any questions, we can leave our message. I'll record it. We'll discuss it later. Okay, next, welcome our next speaker, the Dr. Javier Alvera from the Hospital Star Medical and Querétaro, Mexico. The Dr. Alvera is the AO Spine member on the faculty, Mexican Society of Spine Surgeons. His topic is the UBE for the cervical spine. Let's welcome.
Hey, hello. I am Dr. Javier Quillo Alvera, spinal neurosurgeon from Mexico, and I appreciate your invitation to share my talks about unilateral biportal endoscopy for cervical degenerative spinal pathology. First of all, I want to congratulate the organizers of the event and the International Society of Unilateral Biportal Endoscopy for putting together a great lineup in this symposium. Well, my talk aims to cover the following topics: the basics regarding biportal endoscopy, the rationale of unilateral biportal endoscopy for cervical degenerative pathology, the commonest biportal endoscopic approaches to the cervical spine, some case examples resolved by UBE, and my conclusions. In fact, unilateral biportal endoscopy was reported for the first time in Argentina by Dr. Daniel Julio D'Antoni. He published a paper about indications and experience treating patients with mild degenerative changes and focus on soft epidural pathology dependent on the lumbar disc through a translaminar route. Since then, the scope of biportal endoscopy has expanded, and nowadays we can treat the most degenerative pathologies in the cervical, thoracic, and lumbar spine, assist lumbar interbody fusion, or do some techniques for treating lumbar pain generators, among others. Also, different companies worldwide have launched complete sets for the technique, allowing implementing technology within reach of all experts who wish to offer these minimal invasive techniques to patients. And the expansion of the UBE technique is not only through the industry. New academic proposals will allow the technique to be shared and disseminated to more spine surgeons worldwide. Recently, new societies have been launched to train more surgeons by experts in UBE. This phenomenon is the beginning of the popularization of the technique worldwide. We saw it with tubular surgery, with uniportal endoscopic surgery, and we will see it in biportal endoscopic surgery. We can make easier the UBE technique if it is divided in goals. Unilateral biportal endoscopy can be systematized for its correct execution, since despite being applied in the cervical, thoracic, or lumbar region, it has primary goals that must be completed to achieve the surgical objective. The surgeon should first be familiar with the triangular approach, since this is one of the most challenging steps seen by beginners. The main goal of the approach is to achieve a correct triangulation of the ports. It should be remembered that in UBE, one port is used for the endoscope and the another as a working channel, and that its rostrocaudal location depends on if the surgeon is right-handed or left-handed and the laterality of the disease. For right-handed surgeons addressing the right side, the endoscopic port is usually located on the cephalic incision and the working channel at the caudal incision. The planning of the incisions depends on the radiological anatomy in the region that we are working on. Subsequently, it is essential to collocate the surgical instruments with the endoscope. This will allow the surgeon to orient and continue. Then we must verify that the flow of the saline that enters through the endoscopic portal has a correct exit through the working portal, thus avoiding the risk of tissue edema or other subsequent complications. And finally, the surgeon will need to identify the bone landmarks during the initial steps, remembering that the bone is our friend, and recognizing these structures will allow us to preserve them as much as possible. Thus, necessary iatrogenic instability associated with decompression. Finally, decompression can be accomplished and the purely endoscopic procedure can be safely performed. Cervical region has special anatomical features that must be considered and identified. The biportal endoscopic cervical approach is through a posterior route. Therefore, we must know that deep muscular structures, such as the deep cervical extensors muscles, the transversus spinalis group, or the so-called multifidus group that stabilizes to prevent forward head position, must be preserved as much as possible. In this picture, you can observe the preserved multifidus muscle, which runs obliquely on the cranial lamina in the cervical segment. One of the bone reference that can give us the most orientation is the B point. The B point is a surgical landmark used in posterior cervical approaches, since it allows us to recognize the laminofacet junction. However, this point is not just a bone surface. So this reference has strong implications in the location of the exiting nerve root and the lateral edge of the dural sac in different cervical segments, which has been documented in several articles. In addition, this should be considered as a three-dimensional structure in which not only the superior and inferior lamina converge, but also allow us access to the facet joint in the most ventral aspect. It will enable locating more distal compression sites in the foramen and performing more selective lateral decompressions. In this image, you can see the B point through a biportal endoscopic approach. Here, after drilling, you can see the confluence of the superior and inferior articular process. Here, the pictures with schematic examples are in this side. Here is the B point, and after drilling, you can observe the confluence of the inferior articular process and superior articular process and the interlaminar space. The other structure that we must consider is the yellow ligament. Features such as its sagittal fold, here, the outer layer that blends with the interspinous ligament, and its attachments, the cranial and inferior attachment, must be in the mind of the surgeon, because this structure must be carefully removed to achieve decompression in patients with central cervical stenosis. One of the most important steps to execute properly the technique is the position. The patient position used in biportal endoscopic posterior cervical approaches is the inverted triangle prone position, as you can see in this slide. One of the advantages regarding the unilateral biportal endoscopy is that the surgeon can use the usual surgical tools, and the surgical tools are the conventional ones. For example, dissectors, Carson rongeur, pituitary forceps, water-based drilling systems, and a 30-degree endoscope to reach more lateral targets can be helpful. Regarding hydrostatic pressure during a surgical procedure of UBE, different articles suggest starting with low hydrostatic pressures for continuous irrigation. This is relevant since we deal with the spinal cord and the proximity to the brain. Therefore, there is a greater risk of modifying the epidural pressure in critical anatomical structures like the brain stem. Average pressure of 16 centimeters of water is usually adequate according to the recommendations based on expert opinions. And what are the reasons to use UBE for cervical degenerative pathologies, including cervical spondylosis and myelopathy? And some reasons are the following: to minimize the collateral effect of the surgical dissection and the procedure related, to obtain maximum visualization, magnification, and illumination during the procedure, to offer a safer surgery. And this concept is fundamental, remember it, to get an excellent short-term outcome. So why? A good short-term outcome is a stronger predictor of long-term outcomes, and the efficacy of nerve decompression, decreasing the extent of iatrogenic collateral damage to muscles, ligaments, facet joints, nerves, and epidural space leads to a good short-term clinical outcome. So unilateral biportal endoscopy achieves that. And finally, the technique can be familiar for most experimented and young surgeons, since anatomy is similar to the observed through the microscope, and not all spine surgeons can perform uniportal decompression procedures for many reasons. They don't have skills, the economics, hospital policies, etc. So unilateral biportal decompression in the cervical spine is another option for these surgeons. There are two major UBE cervical approaches to a posterior route. One is the direct ipsilateral paramedian approach, and the other is the posterior inclinatory approach. Neither of them is better than the other. Both have their pros and cons, and both have their scopes. In the left image, you can observe a typical ipsilateral paramedian approach, and in the other picture, posterior inclinatory approach. And you can find fundamentals in the literature book approaches, done mainly by Korean UBE KOLs. Let's start with the direct ipsilateral paramedian approach, which is highly effective in decompressing unilaterally or bilaterally the dural sac and reaching the proximal portion of the exiting nerve. This approach is used for aminoforaminotomy and foraminotomies. The approach lets access to the axillary space by drilling the medial aspect of the SIP and the inferior pedicle. However, since the approach is perpendicular to the facet joint, the surgeon could need more bone removal to decompress the exiting nerve. Here, in this video, you can observe the most proximal part of the exiting nerve decompressed in the cervical region, and the thecal sac has been exposed after removal partially the jello ligament. And then the next is the posterior cervical inclinatory approach. The posterior cervical inclinatory approach is a modified technique from a microsurgical procedure. The UBE inclinatory approach is highly effective in decompressing longer trajectories of exiting nerves. Here, the bone removal is not perpendicular. Instead, the inclinatory trajectory is an oblique medial-lateral trajectory, so the surgeon can observe as a tunnel the approach. It enables the surgeon to use different key cells, diamond bore ending tip drills, and curved ending tip corism rongeurs to accomplish the decompression by undercutting the facet joint in the tip of the SIP. However, its precise nature makes it impossible to address the approach to another pathological target. So here in this picture, you can observe the use of the key cell in an oblique trajectory over the SIP for decompressing the exiting nerve. And in this video, we have enlarged and shaped a cervical foramen in a tunnel using the inclinatory route. Observe the long trajectory of the exiting nerve decompressed and the facet joint preserved dorsally. Another use for the ipsilateral direct paramedian approach is to achieve bilateral decompression of the thecal sac, especially for patients with spondylotic myelopathy. So this approach can be used for the unilateral laminotomy for bilateral decompression. Here in the images, the stepwise technique is summarized. So we first observe and identify the cranial and caudal lamina. Then we perform the partial laminotomy, but if the case requires complete laminectomy, you can do it, depending on the case. Then we observe the attachment, the superior and inferior attachment of the ligamentum flavum, and then we protect the thecal sac with this ligamentum flavum while we crossing the midline by removal of the base of the spinous process. And then we finally perform the flavectomy cautiously. You know, there are some ligaments or some adhesions between ligamentum flavum and the dura of the thecal sac that can lead dural tear during the procedure. So you have to be gently when you perform the flavectomy until decompress completely the thecal sac. Here in this video, you can observe the process of central decompression only. We perform the partial laminotomy until reach the attachment of the ligamentum flavum. Then we remove the yellow ligament, some cases in block, some other cases piece by piece. The point is decompress the thecal sac properly. Okay. So let me show you two examples of cases resolved with UBE technique. So this is the first case. It's a 61-year-old male with right foraminal stenosis at C5, C6, and C6, C7. However, the patient complains also of severe axial pain. In the preoperative images, it is obvious the collapse of the disc height at C6, C7. The red arrow points the finding, but at C5, C6, the height is proper. So we plan a UBE posterior inclinatory foraminotomy at C5, C6, and C6, C7, and ACDF C6, C7. The sagittal postoperative views on X-ray, CT, and MRI show good clinical radiological outcomes after procedure regarding the sagittal balance preserved and disc height collapse at C5, C6 resolved with an interbody device, as you can see in the images. So now please observe the preoperative images. These axial views of CT at C5, C6, and C6, C7 confirms the foraminal stenosis at both levels. So these are the reasons why I choose decompress directly the foramen in both levels through an inclinatory posterior approach with UBE technique. After decompression, you can observe also the enlarged area at the foramen in both levels by using the inclinatory approach, but also here in the 3D reconstructed CT scan, you can observe the tunnel approach in both levels. This is a comparison of lateral views of CT scan, preparative right side lateral view and postoperative right side lateral view. You can observe the severe foraminal stenosis at C5, C6, and C6, C7 in the preparative lateral view of CT scan. And after procedure, you can observe also the enlarged foraminal area through the UBE technique in both levels. Also, you can see in this video how we decompress directly at C5, C6, the right side C6 exit nerve through a posterior inclinatory approach, preserving also possible facet joint. This case example is about 83 years old female with cervical spondylotic myeloradiculopathy and cervical spinal stenosis at C4, C5, and C5, C6 with a modified Japanese Orthopedic Association myelopathy preparative score of 12 from 18. Postoperative images showed sufficient decompression at the levels involved in the disease. The postoperative modified JOA score at 6 months after decompression improved to 16. Also, you can observe here in this video the bilateral decompression of the thecal sac. And a right side foraminotomy at C5, C6 to decompress the C6 exiting nerve. So my conclusions are following. Unilateral biportal endoscopy for cervical degenerative pathology covers a broad spectrum of foraminal stenosis, disordination, and cervical spondylotic myelopathy. The short-term outcome report in a few studies is acceptable. However, the technique requires training and a stable learning curve and a good judgment for deciding and electing the proper patient. More evidence is necessary to demonstrate the procedure-related advantages over others. Thank you so much for your attention.
Okay, thanks for Dr. Alvera for the wonderful presentation. If any questions, please record it and we will discuss that later. Next, let's welcome our next speaker, Dr. Xu Weibing from Dalian Central Hospital affiliated to Dalian Medical University, China. Dr. Xu Weibing is a leading member in the various associations related to spine and is appointed as a member of the spine branch of China Medical Education Association. His contribution to UBE development is widely recognized and approved as one of the key opinion leaders in leading UBE in China. His topic is the clinical application of UBE in lumbar decompression and fusion surgery. Let's welcome.
I'm Xu Weibing from China. My topic is the treatment strategy for foraminal stenosis and far-out syndrome with UBE technique. First, let's talk about foraminal stenosis. The normal foraminal height varies from 20 to 23 millimeter, and the width varies from 8 to 10 millimeter. If the foraminal height less than 15 millimeter or posterior disc space less than 4 millimeter, maybe there will be a foraminal stenosis. Far-out syndrome was first described by Willis in 1984. Of course, FOS only belong to the L5 S1 level. If the disk space decreased, L5 nerve root may be compressed by transverse process spur, thickened fibula, or pedicle. This is a far-out syndrome. The diagnosis of far-out syndrome is difficult from the conventional MRI. However, some special MRI, such as DTI or oblique foraminal MRI, is useful for diagnosing far-out syndrome. And a selective L5 nerve root block is also important for diagnosing FOS. The traditional treatment for FOS and FS is PLIF or MISLIF. However, it is a fusion surgery. How about decompression alone surgery? Now, a minimally invasive decompression technique such as microscope and uniportal endoscopy have been reported a good clinical outcome. Nowadays, with the UBE technique prevalence, it has been used for FOS and FS case. For decompression surgery of FS and FOS, there are two UBE approaches. First, UBE far lateral approach, FLA. Second, UBE medial facetectomy approach, exact SAP tip, including over-the-top contralateral approach and ipsilateral approach. Ipsilateral foraminal stenosis decompression, mainly in L5 S1 level. This is a far lateral approach for L4-5 level. The portal is 2 centimeters outside the pedicle. And at the L5 S1 level, for far lateral approach, the portal is like this. And the left side and the right side is different in this level, a little difference. Approach 2, UBE medial facetectomy or SAP tip, including the contralateral over-the-top approach for foraminal stenosis decompression. And the ipsilateral decompression approach, ipsilateral decompression approach, mainly in L5 S1 level. Let's see some case. Case 1, 60 male. He complained low back pain and left lower leg radiating pain for 1 year. The patient received PLIF 1 year ago and no elevation after the PLIF. From the physical examination, the response for the nerve root is L5. This is the X-ray, pre-operative DR. The patient received PLIF 1 year ago and no elevation of his leg pain. We can see L5 S1 disc space is very narrow. Maybe there is a far-out syndrome. And from MRI, we can see the V-sign disappeared. So the diagnosis is the far-out syndrome post-PLIF. How about your treatment? Traditional PLIF, MISLIF, or ALIF? The localization, the responsible nerve root is L5. Our decision is UBE decompression only from far lateral approach. Decompression only about the treatment concept of FOS include FS decompression and unroofing technique. Unroofing technique include disc TP spur resection, partial pediculolectomy, and far lateral discectomy, and extraforaminal decompression, including secant ligament and ILA. This is FOS treatment concept. Let's see. The first step is foraminal decompression. We can see the foraminal stenosis due to the SAP tip. First, we resect the SAP tip with an osteotome. We should remember SAP tip resection should piece by piece rather than a block to enlarge the foraminal stenosis. Then we decompression extraforaminal area. Unroofing technique include the ILA area and isthmus spur and this TP spur and partial pediculolectomy and extraforaminal secant ligament. This is the unroofing technique. At last, we check the whole length of nerve root from the ILA to medial wall of pedicle. The whole length decompression completely. This is 2 incision, OD incision and UB incision. Post-OPCT show us the far out area be decompressed and the most articular be preserved. Sagittal CT, SAP tip, foraminal stenosis, and post-OP CT, SAP tip be resect. Second case is a 40-year female, right leg severe pain, couldn't standing and walking. From DR, no instability, just degenerative, and L5 S1 disc space is very narrow. CT, we can see far out area stenosis, lateral recess stenosis. The diagnosis is lateral recess lateral recess stenosis, combined far out syndrome. Both exiting nerve root L5 and transverse nerve root S1 be compressed. We choose the combined approach. IPE for lateral recess decompression, EPC lateral approach for lateral recess decompression, and far lateral approach for FOS decompression. We choose combined approach, decompressed both exiting nerve root and transverse nerve root. This is 2 incision. We do decompression surgery, not do fusion surgery. Third case is a post-OP ASD. The patient received PLIF 30 years ago, and the recent 1 year complete low back pain and right radiating pain and neurogenic claudication. PLIF, 2-level PLIF. Lordosis is very bad From CT, we can see L3 and 4 stenosis and L5S1 far out syndrome. MR L5S1 far out syndrome. We choose UB far lateral approach for FOS. We can see foraminal and far outer area be decompressed and the articular be preserved. Sagittal CT, foraminal be decompressed, foraminal stenosis be decompressed. The sixth case is a complicated case. The diagnosis is central stenosis, L4-5, severe central stenosis, combined bilateral lateral recess stenosis, and the right side foraminal stenosis, very complicated case. MRI shows severe central stenosis, and diagnosis is right lateral recess and foraminal stenosis, compressed exiting nerve road L5 and transverse nerve road S1. Left side recess stenosis, compressed transverse nerve road L5. So 3 nerve road be compressed. We choose UBE, ULBD, decompress 3 nerve road, including contralateral foraminotomy, decompress exiting nerve road, and both side traversing nerve road. So foraminal decompression. This case is a right lateral recess stenosis combined foraminal stenosis, both exiting nerve road and the transverse nerve road be compressed. We choose over the top UBE technique. Decompression both exiting and the transverse nerve road, contralateral foraminotomy, and lateral recess decompression, decompressing exiting nerve road and the transverse nerve road. Preserve the articular, not need to fusion surgery. It is UB over the top contralateral approach. Post CT. Last case is ischemic spondylosis. The diagnosis is ischemic spondylosis and foraminal stenosis. We choose mini Elif and percutaneous pedicle screw physician. Mini Elif is indirect decompression without canal invasion. Thank you. Thank you.
Okay. Thanks for Dr. Chu's wonderful presentation. If we have any questions, we can leave out messages or discuss that later. Next, let's welcome the next speaker, Dr. Kanji Sasaki from the Seiri Hamamatsu Hospital, Japan. Dr. Sasaki is a member of Japanese Orthopedic Association, member of Japanese spine surgery and related research. His topic is cage insertion technique of UBE fusion. Welcome. Yeah.
Yes.
Okay. So thank you, Chairman. Thank you, everybody. So I will talk about cage insertion technique. So with UBE. So this is no decompression fusion technique, and it will be a good option of endoscopic in the body fusion. What is MIS? So small skin incision, preserving structures, which is most important. So although it is important to reduce the size of skin incision, especially in spinal fusion surgery, sacrificing the stability of spine is contrary to the original law of minimally invasive surgery. MIS TLIF is a unilateral laminectomy with a cage, which minimizes the skin incision, but destroys the facet joint on one side. In XRIF or F, a separate skin incision of about 3 cm is made, but the destruction of bone, muscle, and ligament is minimal. So TLIF, at the same time, we can do a yellow ligament resection. Then it means posterior decompression and fusion. XRIF or F, if we need to decompression, we will need to add decompression from posterior. So it is interbody fusion only. The concept of indirect the concept of indirect decompression by lifting the intervertebral disc is necessary to complete the fixation procedure without cutting the bone. XRIF RF relies on indirect decompression. What is indirect decompression of RF? So this is case presentation. So RF is performed without bone resection, without ligament resection, decompression completed. And the effect in that decompression is widely known in papers. So otherwise said, pre-op and post-op MRI scans show a significant increase in dural sac dimensions. Sato said, lumbar anterolateral fusion without laminectomy may be useful for lumbar spondylosis with back and leg symptoms. Okay, the shortcut to complete fixation is stabilize unstable intervertebral body by big cages. We can easily do reconstructive disc height and lateral strip. Usefulness of big footprint cage is also increase the disc height. Correcting slippage sclerosis can reduce the deflection and thickening of yellow ligament. We made aware of importance of cage size of relief by relief. So problem, this is a very bad case of small footprint cage by TLIF. Bone erosion progressed, screw loosened and subsided. This inflammation and bone resorption is a specific phenomenon of small cage. The small cage cannot support the vertebra and the bone become inflamed and dissolve. Indirect decompression is only possible if the cage is stable. I think really LF is easy and gentle for bone. Of course, it means so retractor depend, no bony resection, no look of cardiac equina or nerve root, but I doubt it is safe or dangerous. Potential risk of lumbar flexus, psoas muscle, and bowel injury, and vascular injury. and if it occurs, it may be difficult to control. So less invasive and more safety surgery is modern style. Simpler, faster than conventional interbody fusion, less invasive than conventional interbody fusion, safer than conventional interbody fusion. There are no serious complication. It's important. I still want to insert large cage from posterior with minimum invasion. So, therefore, I come up with two clinical questions for posterior fusion. First question, how to insert big cage like LF from posterior? How we can reap the benefit of indirect decompression from posterior? And second question, how to minimize posterior surgery? Uh, minimum invasion means small skin incision, less muscle damage, less bone resection. So I want complete everything as much as possible. I met extraforaminal lumbar interbody fusion for the treatment of ischemic spondylosis in 2014. So Bayek et al. Said they try to approach directly to region the exiting nerve root decompress and stabilize with minimum invasive procedure. Through extraforaminal approach, we can expose the exiting nerve root only to perform interbody fusion without intra-abdominal dissection or exposing central dura and transverse nerve root. Only partial SAP resection it need, and so the amount of bone resection is quite small. I'm sorry. Extraforaminal interbody fusion need indirect decompression. So UBE without a dedicated retractor, if without exposing the dura mater. So, and I think UBE match if. If the cage can be inserted from both sides, the cage size can be increased to 720 millimeter square. Since ERIF has no destruction of lamina, does it leave a posterior element when inserted from both sides? The around 200 square millimeter footprint that started at TIRF is now around 700 square millimeters, which is similar to the effect of 900 square millimeter relief cage. We've reached the indirect decompression, I think. So 700 square meter bilateral site is very powerful. Not only stabilization, but correction, spread disk, etc. We can manage stable cage insertion from posterior by UBE ERIF. Why not TIRIF? UBE TIRIF means with decompression. Put the cage under the endoscope with the dura and exiting nerve root being pulled. It is severely difficult and we don't need to do. So, and indirect decompression without bone shaving is ERIF and it is less invasive than UBE TIRIF. And we selected UBE ERIF. So each approach has a different free length. I'm sorry. Okay, each approach has different free lengths from the skin to the vertebra and different thickness of content of soft tissue to the disc. UBE is approached from slightly more median angle than PET or regular FLA. An approach that does not expose the dura with posterior penetration. Inside the cage through the Camping safety triangle. Perform a SAP resection and enlarge Camping triangle to insert larger cages. Posterior fusion from Camping triangle by UBE is a three-step procedure. Step 1, SAP partial resection. Step 2, making working space at Camping's triangle. And step 3, disc resection and fusion. This is step 1. Identify facet and resection of SAP. Now this is SAP. We can find SAP only touch by spatter, and now I am finding the facet joint. Oh, this is now facet joint. Only exposed facet joint is important. And drawing the SAP. It's a little difficult to do with door, so because of the snowstorm. Okay. And checking the exiting nerve root and reveal disc. So adding cut of the bone. This is step 2, making working space at Camping's triangle. We can enlarge the working space from middle to the outside. So and maybe 14 millimeters length is needed to insert 12 millimeter cage. So this is the disc. So and step 3 is disc resection and fusion. So disc resection and cage insertion without much bone resection is important. Now, so now cage trialing. Okay. So of course, the important risk is in endoscopic fixation is bleeding. Of course, this is a yellow ligament, and of course, the ventral side of the transverse interosseous ligament is penetrated by arteries, which makes endoscopic surgery difficult. And so this is a very technical area, and I use flow shield to do, or if we cannot stop breathing by electrical devices. Our next step is unilateral double cases. So UV posterior fusion with PPS we did. And so case size is very big, and all the numbers and pain disappeared after surgery. But it's a little difficult and technical compared with both compared from both sides. So our conclusion is the development of LF has allowed me to experience the effect of indirect decompression. I figured that this effect was based on the size of cage, so I figured out a way to put in a larger cages from posterior without destroying posterior element as much as possible. As a method, a new endoscopy procedure was introduced. As a result, intervertebral fusion was possible through only 4 ski incision in PPS. And so I think so UBE much if, and it will be a very good option for the spinal posterior fusion and indirect decompression. So thank you for hearing.